I am Valentin Fuster from New York, and I'm very pleased today to continue our usual program that we have every year about spending an hour or a little bit more than an hour about the main trials that are presented in this particular meeting, the American College of Cardiology sessions. Now, today is a very special day, of course, and I want to wish you and your families and your friends and the best. You know, it's a very difficult time. We could have avoided to have this session, but, you know, we have to keep moving, and hopefully at the very end, we will succeed and maybe we will have a better world. So having said this, as usual, I have outstanding colleagues who are going to be working with me through what I consider the most interesting trials, those who present a new concept. There are other important trials that actually are continuation of before, but we are going to present a number of them that are quite, in my view, interesting from the conceptual point of view. And these are my colleagues from Mount Sinai, all recognized internationally, so I'm not going to start giving titles here. David Adams, certainly he will be able to tell us about his views about surgical aspects that we will be presenting. Vivek, Reddy, there is not much electrical information today in this meeting, but I will ask you tough questions to see how you answer them that are not electrical. And then we have Dr. Roxana Mehran, of course. She knows real expert on intervention and on pharmacology. Very ideal to have her here today because there are a number of studies that she will have to comment on. And certainly Anu Lala, I really appreciate very much her presence here, a young star in the field of heart failure. So having said this, let's now move into what I consider is the bottom line of what we have to discuss today. A number of trials, one after the other. I will be presenting the main features of the trial, and then we will have a short discussion. So let's begin. The first study that I would like to discuss is the Victoria trial. The Victoria trial, actually, the title is Vericiquat in patients with heart failure and reduced ejection fraction. Presented by Dr. Paul Armstrong, who is from the University of Alberta in Edmonton, Canada. And it's a very interesting study which has the following background. As you probably know, when we talk about heart failure, there are three mechanisms by which inotropes work. One is the calcium exchange, the most important one. One is directly through the sarcomere. And the other one is about enhancing energy through the mitochondria. That's the third one where this paper relates to a pharmacological agent, Vericiquat, that actually works to the guanylate cyclase stimulator, which is very interesting because decreases oxidative stress and increases the liberation of nitric oxide, which may affect favorably the heart and so the vascularity. We are dealing here with a high-risk population of patients with heart failure. These patients had for a while heart failure and then is exacerbated. And it's at this time that the randomization takes place. This is a randomized, double-blind, placebo-controlled international study of over 5,000 patients with chronic heart failure. And they have an ejection fraction of less than 45%, and the heart failure somehow gets worse. So the randomization is between Vericiquat with a target dose of 10 milligrams once daily or placebo. The primary endpoint is a composite of death from cardiovascular causes or first hospitalization for heart failure. The median follow-up is close to 12 months. Now let's see what happened with the results. First, the primary outcome. I mentioned the combination of death from cardiovascular causes and hospitalization for heart failure. Results. There were the number of events were 35% for the Vericiquat group versus 38% in the placebo group. The results were significant. Second issue is about hospitalization only for heart failure, 27% versus 29%. Again, favoring the drug. Then we have death, the mortality of cardiovascular causes, 16% versus 17%, no much difference. Death from any cause or hospitalization for heart failure. Before was the primary endpoint was cardiovascular death. This is in general, 37% versus 40%. And finally, what about symptoms? When symptomatic hypotension, actually 9% versus 8%. More hypotension with the drug, and a little bit more syncope, 4% versus 3.5%. And these are the conclusions. And I read as they are appear in the New England Journal of Medicine, published at the same time as the presentation. Among patients with high-risk heart failure, the incidence of death from cardiovascular causes or hospitalization for heart failure was lower among those who received vericiguat than among those who received placebo. Well, this is the study, and I would like to ask Anu the first question. You know, we are dealing with a difference. I think it's a great study, but the difference between 35% events versus 38%. Is this impressive? Or maybe this is the opening door that we will have other patients, perhaps with higher risk. And I'd like you to answer this question.
Thank you so much, Dr. Fuster, for this opportunity to join you and the other luminaries on this call. I think you bring up some very good points. We're targeting a very sick population, and particularly we're targeting a population that is vulnerable in that they've had a recent event. And this is very akin to the population that we just saw the results of the PIONEER study in, with sacubitril/valsartan exerting positive benefits. And oftentimes clinicians are worried about initiating therapy for heart failure with reduced ejection fraction, or even continuing therapy, because they've just had an event, they may be hypotensive, or they're considered vulnerable. And I think this is really the key opportunity to make sure that they're on the right medications and to improve outcomes. And this drug now adds to the armamentarium that we have to improve outcomes for patients, but it should not supplant or not include the medications that we already have in use that really do improve outcomes. So I think it's opening the door, but we should continue what we have.
Thank you, Anu. I'd like to ask Vivek a question. Vivek, what we have learned about the inotropes is that they can alter the electrical system. And, you know, this is an inotrope that really works on the energetic of the heart. There's no data here about arrhythmias. No, at least I didn't see it. But Vivek, I'd like to ask you, are you concerned when we come up with new inotropes?
No, Dr. Fuster, thank you. Thanks for, first of all, for squeezing something rhythmic out of this trial for me to talk about. I think it's a very important point. It's a good thing that the cardiovascular death rate has not changed appreciably. You know, the mean ejection fraction in these patients are around 30. So I assume that the majority of these patients had defibrillators or CRT devices. So I'm sure that sub-studies will inform us in terms of whether or not the incidence of ICD events and shocks has changed appreciably. It's also going to be important to understand whether or not atrial arrhythmias are important. We know that atrial arrhythmias can worsen heart failure. Again, the fact that all of the clinical endpoints, mortality, heart failure hospitalizations are going in the right direction, I think mitigates those concerns. But I would definitely like to see what the device diagnostics show us once they actually have that data.
Thank you very much, Vivek. David Adams, I'd like to ask you a question. You have been one of the pioneers in the field of transplantation, cardiac transplantation. How do you see the field of heart failure in the way of treatment since you started to do heart transplantation a large number of years ago? I'm sorry to say that, but you still look young. Things have evolved, and what is your impression? You still have made significant contributions to this field.
Yeah, Viv, I think that we're I think if you look in the long term, we're going to move more toward medical therapy and much more toward small mini pumps. I think the future is going to be partial support, if you ask me.
Interesting. I am very interested, Roxana, when we interview our fellows, there are so many fellows who want to go to heart failure. And obviously, I have evolved in a time that heart failure means bad news. It seems to me that we see something that I think this is in the paper today. Pharmacology is evolving, new devices are in place. Transplantation, maybe we have a problem with donors in general, but it's doing better. So give us your feeling about this particular specialty from your side.
So a couple of things. First of all, I think heart failure is very, very exciting right now, and it's opening the doors. And we, as interventionalists, are becoming more and more involved and working closely with our heart failure colleagues in a multidisciplinary approach. And our cardiovascular surgeons, we're all working together. And I think this is a great, great area. And we're seeing more and more interesting, exciting multidisciplinary approach. So this an attractive field. But I wanted to just bring up a couple of points about this study. This particular study with this particular drug is looking at a different pathway, as you said, with the nitric oxide, which I think is exciting. It's only a relative risk reduction of 10%, and only about 10% of the patients were on Entresto or sacubitril valsartan. And so I wasn't as blown away, of course, as the early pioneer studies. And I think Anu did a great job to tell us that this, again, it's nice to have competitors in there. We still need answers for acute heart failure and normal ejection fraction preserved heart failure data.
Thank you very much, Roxana. Well, we'll discuss the first paper. Thank you very much. And so we have a lot of work to do this afternoon. And let's go into the second paper then. Second paper is entitled VOYAGER PAD, peripheral arterial disease. In fact, the real title, as it comes into the New England Journal of Medicine, is rivaroxaban in peripheral artery disease after revascularization. The paper presented by Dr. Mark Bonaca from the University of Colorado in Aurora, and is a very interesting paper about peripheral vascular disease. And let me introduce the subject. Patients with peripheral vascular disease who have undergone lower extremity revascularization, they appear to be at important risk of problems, number of cardiovascular events. What I think is interesting in the literature is there is no antithrombotic agent that actually has made a difference. We talk about anticoagulants, we talk about aspirin, we talk about clopidogrel. If you look one by one, none has made a difference in these patients who in a way are at a high risk. And now here we are with a new oral anticoagulant, rivaroxaban, and I think it's interesting just to test it. It's not been tested before. So we are dealing in a double-blind international study, patients with peripheral arterial disease who had undergone an acute revascularization, I have to say surgical or endovascular, both, one or the other, I mean. They were randomized, assigned to receive rivaroxaban 2.5 milligrams twice daily, plus aspirin, or placebo plus aspirin. The primary efficacy outcome was a composite of acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or death from cardiovascular causes. The safety outcome was looked in two different ways, looking at the TIMI study or the International Society of Thrombosis and Hemostasis, the ISTH approach. Let's now go into the details of the results. The number of patients that were randomized with peripheral vascular disease in these two modes of therapy actually were about 6,500. Now, when we look at the results, the rivaroxaban group versus the placebo group, the primary effective outcome, efficacy outcome, and I already mentioned the different variables that we talk about it, actually at 3 years was 17% in the rivaroxaban group versus 19% in the group placebo. Now, when we go into, and this was significant, very significant, when we go into the TIMI measure bleeding occurrence, there was no significant difference. But when we go to the ISTH, the difference was incidence of bleeding when rivaroxaban was used was about 6%, and the placebo group was about 4%. And this is actually the summary, again, in the New England Journal of Medicine, and it's the following, and I quote: in patients with peripheral artery disease who had undergone lower extremity revascularization, rivaroxaban at a dose of 2.5 milligrams twice a day, plus aspirin, was associated with a significantly lower incidence of the composite outcome of acute limb ischemia, etc., etc. The incidence of thin mesh bleeding did not differ significantly between the groups, but the incidence of bleeding of the ISTH was significantly different. This is a study, and I want to ask you, Roxana, again, a statistical issue. Here we have the difference in terms of effective outcome between 17% and 19%, maybe a little bit more. It's about 2 points, 2.5 points, okay? The difference in bleeding is also the same, 2.5 points. So how do you buy this?
So really good, really good question. First of all, number one is that this is the largest study for peripheral interventional cardiology. I think it's really important to note that. We've never had a study as large as this for patients who undergo peripheral vascular intervention. So yes, you're absolutely right. The relative risk reduction was 15%. With the absolute risk reduction was exactly 2.6%, with an increase of the ISTH bleeding. They did not show, I didn't see the BARC 3 to 5 bleeds, which would include both TIMI major and minor, and I suspect that those would be higher. However, I think there's no question, if you look at these patients, an acute limb ischemia was the driver of this primary endpoint. And so I think it is still very important. And at the end of the day, we have to risk assess our patients, those who are at very high bleeding risk, not to give them this long-term therapy. This was out to 3 years. The benefit was started to be seen at 3 to 6 months. But I agree, there is a risk balance ratio here that needs to be taken into account when we treat the patients.
Well, it's interesting, Anu, we are looking more and more at these drugs, the NOACs. I can see they are invading the whole system, as we will see later, in peripheral disease, in coronary disease, native, after intervention. What do you think from your perspective, working in heart failure? Are you impressed about what is going on pharmacologically in terms of the atherosclerotic process?
Yeah, thank you, Dr. Fuster. I think we in the heart failure community are also sort of becoming more and more comfortable with using the novel anticoagulants in a variety of settings, be it heart failure with reduced ejection fraction and LV thrombus, or certain cases of myocarditis. And quite frankly, our heart failure patients are at risk for thrombotic events in and of itself. And so I think the field is evolving, and we're constantly evaluating the benefit-risk ratio between bleeding and between preventing adverse events. I think it certainly we haven't seen it in the low EF population. Rivaroxaban was studied specifically in the low EF population to reduce adverse events, and it was not a positive study. And so I think more awaits us in terms of the heart failure field itself.
Vivek, do you know how to spell warfarin?
Yeah. I think that
you forgot about it.
I have. I think most of us have forgotten.
They don't know about warfarin at all. So, are you impressed about it? You deal with the atrial fibrillation, and you deal with ablation and so forth.
Yeah, when I was looking at this trial, I mean, I think Roxana's points are correct in terms of trying to balance limb ischemia, and which is obviously a critical issue. I was looking at this trying to get hints of what this means for embolic events. We don't know what exactly this population is in terms of what % of them had atrial fibrillation, so it's still a little bit unclear to me. And we don't know what % developed atrial fibrillation over the course of the trial. But it is interesting, when you look at ischemic stroke, and you look at it between groups, there was no real significant difference. I mean, the hazard ratio is 0.87 with very wide confidence intervals. And in my mind, this is again, dosing may matter, but it's interesting that this is consistent with some of the other trials that all suggest that NOACs may not have any particular benefit for non-cardioembolic stroke. So this is consistent with Navigate ESUS and Respect ESUS. The other interesting thing, though, on the other side is I was also struck by the fact that at least at this dose of rivaroxaban, its addition had no effect at all in terms of intracranial bleeding. And the ICH rates were numerically actually even better in rivaroxaban, and there was no statistically significant difference. So just from my field, I look at it both ways. It reinforces the concept that it doesn't help in non-cardioembolic stroke, but it also seems to be quite safe at this lower dose.
Except I have to ask Roxana for a moment. I remember the COMPASS study. The regimes were exactly the same, but this was coronary disease and cerebrovascular disease, and there stroke was the difference. And so in coronary events, I wonder why in this study, all these events that are cardiovascular other than the legs are actually, even few patients get events like that. I suspect it's a selectivity process here. Not correct?
100% correct. I mean, this is the same exact dose as COMPASS, 2.5 milligrams BID with aspirin. 50% of these patients, though, did receive clopidogrel. I believe if you look at the paper, and some of that bleeding might have to do with the fact that they received background clopidogrel on top of aspirin and rivaroxaban, and that could be one of the reasons why we're not seeing all these other effectiveness that we might have seen. If you remember, COMPASS was stopped prematurely based on the fact that there was mortality and stroke benefit. So, your point is very, very well taken, and I think we have to again consider this as an additional group of patients that may benefit.
Thank you. David Adams from the operating room. These new drugs, are you becoming more and more familiarized with? Oral anticoagulants, yeah.
Not post-operatively, honestly. Most patients are still in warfarin by the time we're taking care of them. But I am interested in this. I think it's very interesting to hypothesize why this worked. Like, what was the mechanism? Because this is a fairly hard endpoint, revascularization or the need for an unplanned limb revascularization is a pretty hard endpoint. So I'm curious what others think about the mechanism of this. Well, is this the small vessel or large vessel?
We may talk about this later, but certainly what we know about the drug is really antithrombotic. Whether it's the small vessel, what really the work is being done on the large vessel, I'm not sure. And it's very difficult to grasp from the paper, I think. That is a good question. Well, thank you very much. So we have done 2 papers, and I want to do 10, so better we move on. And now comes the third one, a POPULAR-TAVI trial. This study is entitled A Randomized Open-Label Multicenter Study of Oral Anticoagulation with or without clopidogrel after transcatheter aortic valve implantation, a very hot issue. Dr. Vincent Nijenthuis from the St. Antonius Hospital in Nieuwegein in the Netherlands presented this study. And let me now say a few things about the background. I will start saying that I think 98% of these patients get atrial fibrillation. Although we are talking about TAVR, that's the important we keep in mind. So we know that without atrial fibrillation, the incidence of bleeding with TAVR has been quoted between 3 and 15%, and a stroke between 1 and 8%. In about 30% of patients who have atrial fibrillation, 30% of patients undergoing TAVR have atrial fibrillation, and the incidence of these events is actually higher. So here's the study. Patients with atrial fibrillation undergoing TAVR are in need of oral anticoagulants because of the atrial fibrillation. But one could say they also need antiplatelet therapy because of the other aspect that is the TAVR. But that is very nice to talk about it, but what about bleeding? This is what this study is all about, is to have a following hypothesis, to use just oral anticoagulants, and here we are talking about the vitamin K antagonists alone, versus vitamin K antagonists plus 3 months of clopidogrel. with the thinking that maybe bleeding will not occur, and maybe by some miracle, maybe the oral anticoagulants alone will prevent the events like death, stroke, and so forth. This is how the study was actually designed. Now the question is how many patients entered into the study and how the randomization took place. Well, this is actually a European study with 326 patients who underwent TAVI. The average age was 81 years. Most of them had atrial fibrillation, as I mentioned. And these patients, male and female, were equally distributed. The patients were randomized, 164 in this oral anticoagulant alone, and 162 during 3 months, oral anticoagulants plus clopidogrel. And then what we can say is that about the oral anticoagulants was not all vitamin K antagonists, 75%, 25% received NOACs. Having said this, then there is a follow-up here, which is about 1 year, and they look at the usual things. They use all bleeding or non-procedural bleeding on one hand, and on the other hand, they use cardiovascular mortality, ischemic stroke, and MI, or third, cardiovascular mortality, stroke, MI, and bleeding. That's basically what they look at. And so now we are going to present the results, and then I will ask you a few questions. Certainly, bleeding was significantly decreased, very significant, from 21% to the drug alone, the vitamin K antagonist, most of the patients, I will say, this was 34% in those who were oral anticoagulants, plus actually clopidogrel. So the results were actually quite significant. And then, interestingly, when we look at the combination of everything, bleeding, stroke, MI, mortality, that is, you can put all together, the results continue to be very significant in favor of using oral anticoagulants alone in patients undergoing TAVR with atrial fibrillation versus anticoagulants plus clopidogrel in 3 months. 31% for all anticoagulants alone, 45% when you use actually the combination of both. What is interesting, and I don't understand it, is anticoagulants alone were a little bit better in the decrease of mortality, ischemic stroke, and MI than it was oral anticoagulants plus clopidogrel. In fact, 13% versus 17%. I don't understand this, although the results were not actually significant. Maybe that's the key issue. So here we have the final, I would say, summary of these, and this is these patients. In patients with a well-established indication for oral anticoagulants undergoing TAVI, atrial fibrillation, oral anticoagulants alone, as compared with oral anticoagulants plus clopidogrel, reduce the rate of bleeding events, including Mesha-like threatening or disability bleeding. And in this case, is superior and does not increase the rate of thrombotic events. That is a little bit better. So here we have a study, a fascinating study that makes me think, Roxana, about your good husband, Dr. Dangas, presented recently in the Galileo study. Because the Galileo study, if you recall, were patients undergoing TAVR, in which actually, in this case, rivaroxaban plus aspirin was used, and there was didn't work well. So I'd like you to give your opinion about this new possibility that using an anticoagulant alone, maybe that's what we should do after TAVR. I'm asking this question.
100% correct. Galileo was a huge study, 1,500 patients, but none of those patients had a requirement for an oral anticoagulant. Here, you have patients with atrial fibrillation undergoing TAVI, so they're elderly. Bleeding is incredibly important. And remember, in this trial, they excluded patients who had a DES 3 months before or a BMS a month before. So they actually excluded patients who had PCI. And that's also a little bit difficult because in those patients, you're worried a little bit for the need of clopidogrel for prevention of stent thrombosis. So in AFib patients undergoing TAVI, these investigators showed in a small numbers of patients, 300 patients, that you could just go with an oral anticoagulant alone. Don't stack the therapy with clopidogrel, because you will cause more bleeding, and you certainly will not have an important thromboembolic event if you don't have clopidogrel on board. And I think that's hugely important. Also, it's important to note that in this trial, the oral anticoagulant for 75% of the patients was Coumadin, and only 25% received a novel oral anticoagulant. So there's still a lot to be learned in this arena, but POPULAR-TAVI really helps us for AFib patients who have no other indications other than atrial fibrillation and TAVI, that an oral anticoagulant alone is probably the way to go.
Anyway, David, it's interesting because, you know, when you do aortic valve replacement with a bioprosthetic valve, you use anticoagulants for 2 or 3 months. And we have been saying TAVR is completely different story. It's completely different. We have to use something else. And this study goes back that maybe we have to rethink again.
Yeah, I think that it's this study has really important implications for TAVR management in general, not just in patients that were in atrial fibrillation, because of course on the one hand we're trying to prevent surface valve thrombosis, and that's why I think anticoagulation after TAVR is going to be an increasingly important topic. And on the other hand, as you say, we're learning that you have to be very careful when you stack therapy. These patients can be very sensitive. And major bleeding, you know, when we talk about a 50% increase in major life-threatening bleeding, what we don't talk about is the number of transfusions. We have to remember the number of transfusions, how it has a big impact on event-free survival. So that may be part of the reason that we're seeing signals about down the road of major bleeding event, even if you survive.
Thank you. I'm going to give a rest to Vivek and Anu, and then let's move on into paper number 4. Time is pressing, but let's be relaxed and move on one by one. The next one is interesting. Partner 3. Well, let's see what happened here. The title is 2-year clinical and echocardiographic outcome from the Partner 3 low-risk randomized trial that Martin Leon and Michael MACC. And I'd like to introduce the subject appropriately, because we already have some data on a shorter follow-up, I believe, and this is going to be a longer follow-up. Let's begin with the background about the partner trials. They have shown that TAVR was superior to standard therapy in extreme risk patients. We all know this. Non-inferior to surgery in high and intermediate risk patients with aortic stenosis. And results from the partner 3, 1-year results, in this low-risk population demonstrated superiority for TAVR versus surgery for the primary endpoint of death, stroke, or rehospitalization. So what was the purpose? To follow these 2 more years. That's basically the purpose of the study. It's the same study, and I'm going to describe it in a moment just for those who perhaps are less familiarized. This is a study with severe aortic stenosis. It is a low risk with an STS of less than 4%, and the score of the thoracic surgical group. The randomization was 1,000 patients with the Sapien 3 valve versus surgery. And the patients were randomized and followed for 30 days, 6 months, and annually they expect through 10 years. This is actually the presentation at 2 years of follow-up. The primary endpoint set it up at the beginning of the study was the composite of all-cause mortality, stroke, or cardiovascular hospitalization. I'm not going to discuss this at this moment, what means severe calcified aortic stenosis or the low surgical risk. And I'm not going to discuss even the exclusion criteria. I think what I'd like to go into the data and see what we learned in these 2 years of follow-up. Well, what we learned is that things stay almost the same. And I guess I can say the primary endpoint, very important. The difference was 7.1% in favor of TAVR at 1 year of follow-up versus surgery. Now, instead of 7.1%, it's 5.9%. And actually, I could go on into all the different aspects. I could go into mortality. A little bit less, was 1.5% difference. Originally, it was not statistically significant as such. Now it's 0.8 difference. That's basically what it is. And then we can go into stroke. The stroke was 2.1% difference, again, in favor of TAVR. Now is 1.2%. So a little bit, TAVR is a little bit doing not as well, but not really very significant difference. And here we have rehospitalization is exactly the same. I'm just going over all the results just to point out what is significant. Valve thrombosis was a little bit increased in TAVR versus surgery. The data is very, very small number of patients. Echocardiographically speaking, the same. In other words, the mean gradient and the aortic valve gradient, hemodynamically is the same. It's the same also paravalvular regurgitation. So let me look at what we learned. Here we have the conclusions of the study. And this is, I read them and I quote as they are presented. In a defined population of severe symptomatic aortic stenosis, patients who were at low risk, low surgical risk, TAVR using the Saphenous valve compared to surgery at 2 years demonstrated reduced primary endpoint events, 37% reduction in death, stroke, or cardiovascular hospitalization. But more deaths and stroke events in TAVR patients from 1 to 2 years, although the difference was not significant. Rehospitalization was actually the same, perhaps a little bit better with TAVR, and increased valve thrombosis was a little bit worse with TAVR, and hemodynamics actually were the same. I'd like to make a point that I think is actually important here, and that is what about the limitations of the study. It's pointed out that there is follow-up data available in the surgical group due to greater patient withdrawal. This is a problem when you go into a 10-year follow-up. This is a 2-year, but I think it's worth mentioning that these are not easy studies to carry on. And I'd like David to give you your overall opinion of the study.
I think, Valentin, when you see the slope of the curves in the TAVR group at year 2, these two groups in terms of outcome are coming much closer together, and we have an anatomic explanation partially for that, which is valve thrombosis. And I think it's going to be very important to follow this at 3 years and 5 years to see where we land.
Thank you.
I think it's concerning. The pattern certainly requires some more careful follow-up.
Okay, Anu, do you have any comments?
Yeah, I think in particular, and I'm sure Dr. Adams might mention this in you as well, is that we did indeed have less follow-up data for the surgical group, but nearly 10% of these patients were not available for the follow-up endpoints. And so I think that also serves as a meaningful limitation in this group. And I think longer follow-up is really necessary to combat the upfront risk we see with the surgical approach.
Roxana?
No, I mean, I think Dr. Adams put it very, very nicely in showing that over time we're starting to see less of a separation and really a non-inferiority between TAVR and SAVR. But the primary endpoint still remains in favor of TAVR when you put all 3 endpoints of death, rehospitalizations, and stroke. And I think it's an important endpoint to make sure that we remain there. But the valve thrombosis is a little bit of a question. 13 events in TAVR versus 3 in up to 2 years in the surgical valve. And I think that's really important for us to pay a lot more attention and refine our anticoagulation and antithrombotic regimens after TAVR.
And Roxana, I don't know what rehospitalization means after surgical AVR, what it's for, but I think it's a mistake to equate those 3. I know I don't mind coming back in the hospital, but I prefer not to die or have a stroke. So I think that these curves are getting a lot closer, and I think we're just going to have to follow and see what happens, because remember, these are low risk. These aren't high risk patients. These are low risk patients.
Vivek,
No risk patients, the real benefit we'll see is whether the surgical valves continue to look like what they did here, which was to outperform them in the long term. And that may be due to crimping or other issues at the tissue level, not the procedural level.
Vivek, can you hear me?
Mm-hmm.
I have a question. Vivek, I have a question. You are running a number of trials, and this is what concerns me. We need long-term follow-up. This is just 2 years. Should we tell patients when they sign up that this will be a long follow-up, even that they don't have to do anything substantial after the drugs are being given and so forth? Because we are going to see more and more of a problem of the key question that we have in most of these studies, the long-term data.
No, I mean, it's a good point, Dr. Fuster. And it's a problem with this trial, with almost any interventional type procedure trial, especially when you're comparing such procedures with such different sort of impacts acutely, or particularly if you're comparing procedure versus no procedure. But there's a lot of these questions can be answered with large non-randomized studies. I mean, the question of valve thrombosis that David pointed out, I mean, it's something that we can understand. Obviously, you'd love to have differential information, but at least you can understand the incidence of this. Or just in this particular trial, when I look at pacemaker implantation rates, one of the things that you always get concerned about when you think about a TAVR type procedure is we know that there's an acute rate of damage to the conduction system requiring pacemaker implantation with new left bundle branch block. And the question is always, is that going to translate to later pacemakers? And so far that hasn't been the case. And I think that I'd like to continue to see this because there's a much higher rate of new left bundle branch block. But you could follow that in good follow-up non-randomized registries too.
We have more to say about this with Roxana actually later, the long follow-up. Let me now move into the next paper, which you say, why in the world you present this paper, rivaroxaban or enoxaparin in non-measured orthopedic surgery? What the cardiologists have to say about this? Well, look, I think this is an interesting paper, actually. It was also published in the New England Journal at the same time. This is the PRONOMOS study. This is a study that, was presented by Dr. Nadia Rosencher, and the first author of the paper is Dr. Marc Samama from Paris. Now, this is a story. We all talk about hip replacement, we all talk about knee replacement, but there are many orthopedic procedures that are actually Achilles tendon, knee surgery, not necessarily replacement. And there is a very controversial guidelines from Europe and the United States whether these patients with this kind of more minor surgery should actually be treated with antithrombotic therapy. There's no question about hip replacement and knee replacement. So why? Because these patients are in some immobility for a few days, and therefore it is nice to see something has to be done. And this is why this study was actually developed. This is an international randomized double-blind non-inferiority trial, randomly assigned adult patients undergoing lower limb non-measured orthopedic surgery who were considered not to be at risk for venous thromboembolism. This is in terms of clinical judgment. And they received either rivaroxaban or enoxaparin. Rivaroxaban, both drugs actually for 2 weeks, 10 milligrams a day for rivaroxaban and 40 milligrams subcutaneously of enoxaparin. And the patients were followed for a primary efficacy outcome of measured venous thromboembolism. I'm not going to spend time to define these because also includes pulmonary embolism, proximal venous thrombosis, etc. There was a safety outcome, of course, to be looked at of measured bleeding and not measured bleeding. And the number of patients that were actually randomized were about 3,500. Results. The primary endpoint of measured venous thromboembolism, 0.2% in the rivaroxaban group versus 1% in the enoxaparin group. Actually, in terms of the incidence of bleeding, there was no much difference. It's about 0.6%. So here we have a study telling us that rivaroxaban, and I quote the conclusions as they are in the paper, rivaroxaban was more effective than enoxaparin in the prevention of venous thromboembolic events during a period of immobilization after non-measured orthopedic surgery of the lower limbs. And I have two questions for you, Roxana. Because, you're moving from 1% to 0.2%, and this is in terms of effectiveness in preventing venous thromboembolism. But in terms of measured bleeding, you move about 0.6% to 1%. And again, I am asking the question, is this why there is controversy in guidelines, whether we should use these agents or not? And the second question is, again, Novax is coming everywhere. Now we have rivaroxaban again. You can briefly answer both questions.
Yes, I think, when I look at this rivaroxaban 10 milligram QD dose, which was the exact dose we used in Galileo. And here it was superior to a subcutaneous low molecular weight heparin in reducing really important DVTs in patients. But it was 4 events in the rivaroxaban arm versus 18 events in the enoxaparin arm. And they had to study a large numbers of patients. But here you have an oral drug that you could give to these patients. Most of these were knee surgeries, and there was a major reduction. So I think it's a significant, important outcome. And then the bleeding events were not really that different. I mean, there was actually 14 bleeding events in rivaroxaban, severe, bleeding events versus the same, 19 versus 18. So no real difference. So here, the net benefit is clearly in favor of rivaroxaban.
So these new drugs, these new drugs are for the cardiologists, now for the orthopedic people. They are now getting into the brain people. I mean, everybody's beginning to use them. Give us a statement, just a short statement.
Yeah, I think, this is a population that we don't, as a heart failure cardiologist, interact with very often. I mean, it was predominantly, the mean age here was 40 years old. These are patients who were not considered to be at risk for, I'm sorry? Unless you break your leg, you said. Correct, right. I mean, I have to ask, I wonder what the incidence of venous thromboembolism would be in patients who did not receive any anticoagulant, for that matter. I do agree with Dr. Mehran in that this is an oral anticoagulant, and it does seem to show a benefit, but a relatively small one in a population where the incidence of thromboembolism is exceptionally low.
Okay, thank you very much. We are moving now into an interesting paper. Actually, this is the kind of paper that Vivek really loves it. When he hears about some kind of catheter ventilation or whatever, what is in the kidney or whatever it is, he gets very excited. Let me go to the so-called SPYRAL HTN-OFF MED Pivotal trial. This is entitled basically catheter-based renal denervation in the absence of antihypertensive medication. Primary results from this trial, Dr. Michael Wong from Hamburg SAR in Germany presented the paper, and I think it's interesting for discussion actually. Let's go now into the real issues here. Well, that 1/3 of the adults have hypertension, we all know that. The SPYRAL study actually started with a pilot trial that shows some principles of concept, and maybe this could be meaningful. And this moved into the trial that we are presenting today, the pivotal trial, the prospective trial, randomized trial evaluating renal denervation independent of drug effects and adherence. And I have to go into some details about this. This is a very important, I believe, international study. And I would just say that what kind of patients enter into this study? Well, the patients either were not on antihypertensive medications or the medications were permitted to be discontinued. Interestingly, the blood pressure in the office systolic was equal or more than 150 or less than 180. And the diastolic in the office was equal or more than 90 millimeters of mercury, 150 over 90. And in the outpatient or ambulatory, 24 hours was 10 millimeters lower, actually, than the one I just mentioned. And there were a number of excluded patients here, like those with ineligible renal artery anatomy, a GFR of less than 45, etc., etc. Let's now go into what the study actually consisted of. The number of patients that we are talking about is actually 300, about over 300 patients. The mean systolic pressure in the office was 162, in the 24-hour ambulatory was 151. The average age of the patients was 52 years, 64 were male, and 21% were African American. The patients were randomized into either procedure, and I don't go into the technicalities of what it was done, but I'd like to present some information at least. Number of medial arteries treated were an average of 2.2. The number of branches treated, 5.8. And the total number of ablations averaged 48. And the time of the catheter time, 60 minutes, and contrast volume, 208. Successful procedure, 100%. Certainly is a very aggressive approach to the denervation. That's what I can really summarize. Now we go into the results. Just to mention that results with outcomes other than the ones that we are going to discuss were almost zero, only hospitalization for a hypertensive crisis. What we are interested is in what happened with the blood pressure. That's what the interest is. And I can tell you the results. 24 hours systolic blood pressure, the difference in favor of the approach of the renal denervation, 4 millimeters less. Diastolic blood pressure, 24 hours, ambulatory, 3 millimeters less. Office systolic blood pressure, 6 millimeters less. Office diastolic blood pressure, 4 millimeters less. Okay? That's the story in terms of the results with blood pressure. Now, here is a question that I think is important to mention, and that is a number of patients escaped from the study and the sham group. So this is not easy to handle. And what is interesting, a number of patients actually were taking antihypertensive drugs without telling the doctor. They were identified by blood testing. So this is not an easy study to carry out. But let me give you the results and see then what you have for the discussion. These were patients, uncontrolled hypertensive patients in the absence of medication. In both 24 hours and office blood pressure was measured, and this compared to a sham control. Clinically meaningful blood pressure reduction at 3 months. This is important. The consistent blood pressure reduction was in all the cases that I presented, systolic and diastolic, ambulatory, not ambulatory, and particularly important during the night time when the cardiovascular risk is highest. And in terms of device procedures, safety events throughout the 3 months, really no problem. And therefore, the study is continuing. And I'd like to ask a number of questions. First, Vivek, you like the stuff of denervation. What about you? Like the results?
Yeah, Dr. Fuster. No, I think it's very interesting. After Simplicity 3 came back with such a contrary outcome to what we were expecting. There have been a number of studies since then. There's been the SPYRAL HTN-OFF MED trial that this is. There was a pilot to this trial, which was positive. There was another technology using ultrasound energy, also a similar pilot that was positive. There's the Simplicity on-med trial, which you'll probably want to talk about later, which was also positive as a pilot. So this is the first of the sort of the pivotal trials using different technologies. And I think that, I think it's important, even in Simplicity 3, there was a strong suggestion that there was just not enough ablation done. And you pointed out that there was more ablation done in these patients with actually a better ablation catheter. And they were able to get better outcomes, again, importantly, with no important safety events, no renal artery stenoses, etc. So I think it's actually very impressive. I think that it's also impressive because, remember, some of the patients in the sham group ended up taking medication. So the magnitude of efficacy is probably underestimated. And then the third point in terms of on the efficacy side, these patients, they actually stopped the trial at 3 months. Well, that's not quite right. They were able to look at the data at 3 months because they had a positive outcome. These patients are going to be be followed at 6 months and 12 months. And there's some data from previous studies that the magnitude of difference may be even greater at 6 months than 3 months. So overall, I think it's quite impressive. And the last point, and maybe we want to get into this, is the way they did this, the way they constructed this trial from a trial design perspective, I thought was really very nice. The way they use a Bayesian design to use some of the pilot data, because this is a very difficult trial to enroll for. I really like the way this trial was.
It was an effective study. Dr. David Adams, when you have a patient and you call, the patient has a pressure of 170, 180, if I can drop the pressure to 130, you tell me I'm not doing a good job. So this drop of blood pressure, 5-6 millimeters of mercury, is this is an effective? There's no question. It's an effective procedure. But are you impressed?
Well, in our world, it's a rounding error, VF. We don't get to the second number. We just work on the first two. So whatever 120 and 129 are the same. So I honestly don't know what whether there are other clinical benefits besides just that particular drop in blood pressure.
Thank you, Roxana.
So, Dr. Fuster, I just to add to what Vivek was saying, this study is so incredibly important for the field of renal denervation. It truly is. It's sort of like the lifeline for renal denervation because of the negative study of simplicity. This study was done off meds just to ensure after the pilot that actually renal denervation does have an effect on reducing blood pressure. And I think they have proved that. And now we need to kind of think about a very good way that on top of meds, what added benefit can renal denervation give us in reducing not just blood pressure, but also clinical outcomes? And I think this is a really, really kind of like getting back into the water again with better ablation and showing that denervation actually does work. And that is what we are seeing right here today. And it's not just the office blood pressure, but it's important, this 24-hour blood pressure reduction. And 4 millimeters of mercury on a 24-hour monitoring is actually quite significant. That's what the hypertensive gurus tell me anyway.
No, but Fuster set me up, Roxana.
I was very happy to see the results. You know why? Because of the resilience here. Remember, everything would like fall apart 2 years ago, and people consistently persisted. I don't know where this is going. Let's see. But at least the results were effective, and how people were persistent in looking at. I think they have to be congratulated.
I mean, this field was going to go out the window, and now we actually this trial, how difficult it was. We were an enrolling site. It was impossible to do this. You had to get the patients off meds for a couple of weeks, then get them in. Difficult and unbelievable effort.
Let's see. I would like to see in 10 years where things are. But anyway, congratulations to the persistence.
Wait, Dr. Fuster, can I make just one more point on this? I think
one more point is a small point, very short.
Okay, it's 1 point split into 2 parts.
We don't have time.
Okay, I was just going to say that in terms of magnitude of benefit, the one piece of data that we're missing here is actually the percent of patients that show a significant benefit. Because the reality is there are going to be some patients that probably show no significant difference and others that show a real clinically significant difference. So this average of 9-point difference on the office side is actually really quite significant. You don't see much bigger numbers than this in hypertension trials.
Okay, thank you very much. Let's move into the next paper. It's called the PRECOMBAT study, extended follow-up of the PRECOMBAT study. 10-year outcomes after drug-eluting stents versus coronary artery bypass grafting for left main coronary artery disease, a very hot stuff. Now, Dr. Doo-Woo Park from Seoul, Korea, is the principal investigator and presented the study. And I don't think this needs much introduction, but maybe The introduction is because these were the first people who really addressed left main disease, and therefore it's worth mentioning what the results were at the beginning. As we know, there's a lot of debate about the Excel study, 5 years of follow-up, ECI equal to CABG, and so forth. So it's nice to see this paper here because it goes beyond that time, beyond 5 years. Basically, they had studies already published before that were studies on the first 5 years. And I like just to point out that the original study, the PRECOMBAT trial design, were patients with unprotected left main. There were 600 patients that actually were 61 years of age, 76% male. And then the randomization exactly was about 300 with the cipher. This is very important. The cipher stand, which is not the most recent one type of procedure. I think this is very important to take into account. And the follow-up, they have follow-up at 1 month, 6 months, and then 5 years. I have to say that just to get a sense of these patients, the syntax score was 24. 9% actually have left main alone, 16% one vessel disease, 33% two vessel disease, 40% three vessel disease. And then in terms of the other lesions at the left main, they were comparable to be addressed with PCI and CABG. The patients had either ischemia, or ischemia products were about 5 times normal. So I think this is an important study that, in fact, the ischemia has been demonstrated with left main disease. This is actually the 2-year report and the 5-year report. I just want to say very simplistically, they look at an endpoint at the beginning, which was death from any cause, myocardial infarction, stroke, or ischemia-driven target vessel revascularization. And actually what happened is that in these aspects, it was a trend. I'm talking about the very early results. There was a trend in favor of CABG. And the trend actually was, in some cases, was significant in terms of non-inferiority. Okay, so what they decided to do is to carry on this particular study, and I just like to present to you a way that this has been done. This was initially planned, as I mentioned, for 5 years. I presented to you the short-term data with trends in favor of what I said of CABG. And then this extended into 10 years. How they did it is very interesting. The Korea has actually a universal health coverage system. It's all registered. So anything that you want to do is possible to grasp the data and to then get into studies like the one that I'm presenting today. So these individuals were followed for 10 years, and I just like to give now the report in terms of the primary endpoint. Okay, the primary endpoint at 10 years, PCI versus CABG, left main disease, was actually for CABG 24%, for PCI was actually 29%, a hazard ratio of 1.25. In terms of the composite, now they are excluding ischemia-driven revascularization and only use death, myocardial infarction, or a stroke. The results were exactly the same. Then when they use ischemic revascularization, of course, the CABG did better. When they look at death from any cause, there was no difference at all. So, in fact, if I now go into summarizing the results, this is what we can say. In a quote, PRECOMBAT was a first randomized controlled trial specifically targeting patients with unprotected left main disease. We did not detect any significant difference between PCI and eluting stents and CABG. The PCI with eluting stent and CABG is the first generation, I would say. And in the primary composite death, myocardial infarction, stroke, ischemia-driven revascularization at 10 years. The 10-year composite of death of myocardial infarction was also similar, Finally, the 10-year rate of ischemia-driven target vessel revascularization was a little bit higher for PCI than CABG, as it could be expected. So then we have to conclude that the 10-year follow-up of the PRECOMBAT trial of patients with left main disease and randomized to PCI or CABG did not demonstrate significant difference in the incidence of major adverse cardiac or cerebrovascular events. Because the study was underpowered, the results should be considered hypothesis generating, highlighting the need for further research. In fact, this is what we were saying. Was the number of patients in the study that were not high was 600 patients divided in two groups of 300, and this is actually the data as is being presented. The next, perhaps the final point that I would like to make is that there were some issues in terms of the follow-up, in terms of the data available and so forth. I don't want to go into much detail, but there was some detailed information that was not available and so forth. So I think that the study was as well done as possible, but remember, it's a first-generation stent. So I'd like to maybe ask you, David, what do you think? This left main is so hot, and here you have the longest term study you can have.
Yeah, I think it's interesting. I think it's a point for the left, a point for PCI, which I'm happy for. I think it's still I'm not sure that's going to win the game one way or the other, but I think it's interesting data. I'd like to read the whole manuscript.
Sure, Roxana.
Well, I mean, I think it's this, and as you know, Syntax, which was also a first-generation drug-eluting stent study, much larger in number, and they looked at the left main patients, which was a subgroup of the Syntax patients, and over a 10-year period, there was no difference in mortality. But let's not forget the Excel trial with 2,900 patients randomized to a next-generation, best-generation DES. We ended up with 1,900 patients who ended up randomizing between Xience, which is the best possible stent we could have, versus CABG. And there, the 5-year data for the primary endpoint of death, MI, and stroke was looked like it was exactly the same, but really it was 19.2% for CABG versus 22% for PCI, with the shifting of the mortality as well as the this hard endpoint of death, MI, and stroke in favor of CABG. And so I think when we bring this all together, it's always nice to see that the mortality looks the same, but I still believe we have to be very open to our patients that the early benefit of PCI, perhaps by having a similar effect to CABG, does not really translate to a durable result from CABG that gives you a really, really good enhanced outcome over time. So again, it brings us back to that conversation with our patients to make sure that they understand the early risks and benefits for both of these procedures, and have shared decision-making to make important decisions about the revascularization strategies.
I want to ask Anu, frankly, by being involved actually as an editor of a journal, coming all these dilemmas and studies and so forth, I reached the conclusion that we are having perhaps more of an intellectual discussion than really practical. I'm just giving my opinion. And that is, to me, one or the other are good, and in patients who are not at a very high risk. And I think we are discussing a lot of detail, but I'm not entirely sure we will continue until we get tired of the discussion. Anu, what is your taking?
Yeah, thank you, Dr. Fuster. Dr. Mehran, I'm so glad that you brought up the really important concept of shared decision-making and personalizing medicine for our patients. I think more and more we're seeing patient-centered outcomes being the focus of how we treat our patients, but I think we need to see more about it. I think we need to see more about functional status, about quality of life, about patient preference, patient disposition following a procedure. Are they going home? Are they going to a nursing home or a skilled nursing facility? I think all of these factors come into play when we talk about what might be the right treatment decision for a patient. And I think I really still believe it's very, very much about individualizing the approach and talking to our patients and their families.
Very good point, Anu. I think
if I could just make one more comment, to both you and Roxana, I really believe on staying on that line about personalization. I believe that in both left main disease as well as in TAVR, these decisions in the future are going to be made around your life expectancy and around your sort of long-term projection. Everything is safe. CABG is safe, PCI is safe, surgical AVR is safe, TAVR is safe. And I think that we're going to see a trend back toward, all these trials were done considering risk of patients, for instance, the structural trials. And I think we're going to land as heart teams on what's your projected 10-year survival. And I bet you in the long term, patients that need definitive care and to be cured and have long life expectancies will continue to be pushed towards surgery, and patients with shorter life expectancies or higher risk will end up having structural intervention.
Well, thank you very much for the discussion. I think we have to get into the next paper. The next paper is actually is about the radial artery versus saphenous vein for coronary artery bypass surgery. And also the long-term follow-up, Dr. Mario Gaudino from Cardiothoracic Surgery at the World Cornell Medicine in New York presented the study. And I'd just like to go ahead and give you, at least in a few sentences, what the study was about. Well, this actually evolved the so-called Radial study, which was a meta-analysis of 5 different groups that actually look at the possibility that radial artery could add some benefit to the use of only saphenous vein bypass grafting. And these 5 studies were put together now with a longer follow-up. Actually, the original follow-up was a few years, I think it was 5 years, and now it's been stretched into 10 years. How can you follow patients for 10 years from 5 different studies? Well, this is a very, I have to congratulate how this was done. I have all the ways that were used, database, telephone calls, anyway, you make it, you name it. But the fact of the matter is that the study moved on, and the primary outcome actually was a composite of dead myocardial infarction and repeat revascularization in patients that have one of the arteries, radial artery, that was bypassed, and versus, or maybe the other arteries have saphenous vein bypass, and with another group that all were saphenous vein bypass grafting. The results of this particular study I just like to summarize, and that is the following. At 10 to 15 years of follow-up, the primary endpoint, death, myocardial infarction, and revascularization, you have when the radial artery is used is superior that only when saphenous vein graft is used without radial artery. And the p-value is very significant with a hazard ratio of 0.73. Then the whole thing goes into death and myocardial infarction. Death alone was also significant. It is all stratified into different groups. The final comment here is actually the summary of what is the conclusion of this undertaking, very difficult undertaking. In this individual, I quote, in this individual participant data meta-analysis with a median follow-up of 10 years among patients undergoing CABG, use of the radial artery compared with saphenous vein grafts was associated with a lower risk of a composite of cardiovascular outcomes and a better survival. This is the first report of survival benefit for CABG using multiple arterial conduits based on randomization data. Okay, David, what do you think?
I think very interesting, and I'm not sure. I think we didn't learn much more from the publication in New England Journal at 5 years in 2018. That was only 2 years ago, but the 5-year data was published 2 years ago, interestingly. And I think the conclusions are the same. Again, there are a lot of challenges, not only just with follow-up, but trying to combine these kinds of trials into anything meaningful. But I think that there is certainly a patient population that appears to benefit from radial. When you look at some of the incident curves, you see most of this is won by repeat revascularization in the first few months after surgery, it looks like on the curves, because they're fairly parallel, except for death later on. So again, I don't know what the criteria were for matching grafts and conduits and how all those decisions were made. And you always wonder about experience of surgeon in trials like this where you have so little information about how they got included. But I think there are some interesting signals here. The signal here is a little stronger for women than it was in the New England Journal paper. So, and I'm sorry, in the 5-year follow-up paper. So there's some interesting things going on here. I'm sure we'll continue to talk about the radial artery.
David, can I ask you, are we moving into arterial grafting? I mean, 2 mammaries and the radial artery, like have some people in Australia have recently shown.
Yeah, I think that, this is an old topic, not a new one. It continues to get interest. And I think that the results are mixed, honestly. I think that this is another good discussion to talk about individualization, meaning I don't agree with all arterial revascularization in 80-year-old patients that have 4 and 5 year survival. Many groups do it because they want to tell us what their rate of all arterial revascularization is. On the other hand, I think younger patients, and particularly patients, if you know they don't have a normal saphenous vein graft, my gosh, of course they're going to do better with all arterial revascularization. So I think the answer is much stronger for a second arterial graft than for all arterial grafts.
Okay, thank you very much. I'd like to, just in the context of time, to move into the next paper. An interesting one is about e-cigarettes. This paper is actually the so-called E3 investigators in the trial. It is a randomized controlled trial evaluating the efficacy and safety of e-cigarettes for smoking cessation. This was presented by Dr. Mark Eisenberg and from McGill University. And it's an interesting study in a way that it tells you how difficult to stop smoking is. Well, I don't want to go into the issue or the controversy about the smoking. E-cigarettes may contain nicotine, may not contain nicotine. We can counsel people to discontinue smoking. We can do many things. And these are actually the basis of the study, was to examine the efficacy and safety of nicotine and non-nicotine, this type of e-cigarettes with individual counseling compared with counseling alone. Let me now be more specific. What we have here is 3 groups of people. All actually have been smokers. And in fact, one group out of, I have to tell you the number in a minute, I think are 17 each group. I will tell you in a moment. But one group is nicotine, electronic cigarettes and counseling. The other group is non-nicotine electronic cigarettes and counseling, and the other group is counseling alone. This is actually how they were divided. And the study is really at this time is just focused on about 12 weeks, and is the report of abstinence of smoking, the reduction of the number of cigarettes, if there are side effects, etc. Something that we could discuss in vitro. Here's the number of patients. Okay, the nicotine e-cigarettes and counseling were 128. Non-nicotine and EC cigarettes were actually in counseling were 127. In counseling alone was 121. Average age 52 years, same number of women and men. The average cigarette smoking of this group was actually 21 cigarettes a day of the 3 groups. And what is interesting, 92% of these people who participated they tried to quit the smoking before. So it's a very selective group that at least is trying again and again. I think this is important. Now, let me give you the results, and I don't want to disappoint you, but really are not too good. At 12 weeks, abstinence of smoking was actually 22% in the group with nicotine type of cigarettes and counseling, 17% in the group that were actually with non-nicotine cigarettes and counseling, and 9% in the counseling group. So actually the difference between the cigarettes with nicotine and counseling versus counseling alone was actually a difference of 12.8%. But the maximal abstinence that was achieved was actually 22%. So the results were significant, but really a lot to be desired. Now there is a second issue, and maybe there is no complete abstinence, and then let's see what happens with the cigarettes that are being smoked. Well, an average of 8 on these people and the group that were actually treated with both counseling and they were nicotine cigarettes, 10% in the second group with non-nicotine in counseling, and 14 in the group that actually was only counseling. I'm talking about number of cigarettes. I think the issue of this paper, what this brings up, is that first of all, it's difficult to stop smoking. Obviously, this study apparently is going on, is continuing, but it's difficult to discontinue smoking. And certainly one can say that the use of nicotine cigarettes as a mechanism with counseling to discontinue smoking completely maybe is a possibility, but I don't know how successful this will be in a long term. In a short term, there is a lot to be desired. So I just presented in a very succinct manner what appears to be an interesting approach, but somewhat frustrating at the same time. Vivek?
Yeah, Dr. Fuster, I think it's really interesting. One thing to point out is that the trial was ended up being stopped early because of insufficient enrollment. So ultimately, they only enrolled about 3/4 of the number of the patients that they had anticipated, apparently because of availability of the e-cigarette, which is somewhat surprising. But in any event, it is disappointing.
Disappointing. Roxana?
No, it's obviously a very, very difficult study to do and underpowered for their endpoint, as well as their endpoint was self-reported, which is very, very difficult to obtain. We just don't know what's really going on. And so this could be an overestimation of the benefit rather than an underestimation of the benefit, because it is self-reported. And most people who are told, well, we're going to stop smoking, they'll say, oh, no, I'm only smoking 2 cigarettes a day, when in fact they're actually smoking 18. So I think it's important to note all of those. But you have to give these investigators a lot of kudos for trying, but very difficult. I agree.
A lot of credit to the investigators, no question about it. Well, anyway, thank you very much. Let's move into the last paper. Very interesting. This is about who have ischemia and angina, and they have apparently normal coronary arteries, whether this is a spastic phenomena and the epicardial arteries or lack of dilation or reserve in the microvasculature. This is a very important issue, and we know that actually in a large proportion of women who present with angina or ischemia, this is what we are actually dealing with, and that is the possibility of the so-called non-obstructive coronary artery disease, or INOCA, ischemia with non-obstructive coronary artery disease. Well, having said that, I think this is an interesting study. I think it's full of surprises as the syndrome itself. Let's say from the beginning that this was part of the ischemia study, and I don't have to go into the detail. These were patients with moderate or severe ischemia objectively found that were then had CT angiography. And just to make the long story short, for all these patients, there was a group that actually had non-obstructive coronary artery disease despite of ischemia. These were 21% of the total population. This is interesting. 63 years, women 66%, angina pectoris or atypical chest pain 71%, shortness of breath I think was 49%. And it's interesting, the degree of ischemia didn't correlate very well with the degree of angina. So these are patients which I identify as having ischemia, but the degree of ischemia and the amount of angina, they really did not correlate with each other. Well, having this is actually a descriptive study, a study that you follow for a year and you try to see what's happening. And the patients are medically treated. And the question is this syndrome goes away? Is it stays there? It gets worse? So let's see the results. Number one is interesting. I think this is fascinating. The amount of ischemia and or angina in the group with INOCA and the group with coronary artery disease at baseline was the same. I would have said that people with INOCA will be much less angina, much less this, much less that. Actually, it was exactly the same. And this is the first point to be made. This was actually at baseline. Then at about a year of follow-up, interesting, ischemic patients who had ischemic segments, they normalized in 50% of them. And in 45% of the INOCA patients, had changed or got worse. That's the next thing that it was found. The next question was angina was better in 39% of the patients. So 50% no ischemia, 39% actually better in terms of angina. What is interesting, also in the follow-up, there is no good correlation between the patient who has ischemia and the patient who has angina. So it's like you would like to have everything correlated and you are incapable to, but this is actually the data. So I think the problem of the study, frankly, is there was no invasive testing for microvascular disease was not done. Because the thinking today is these are patients who have spastic phenomena of the epicardial arteries and or lack of the power of dilation of coronary reserve of the microcirculation. And you address the first with acetylcholine to see if it causes spastic phenomena cardial arteries, and you address the microcirculation with adenosine to see that there is no increase in reserve. That's what should be done. This was not done in the study. So, and also the study excluded patients with unacceptable degree of angina. Well, and we don't know much about the medications being given. But this is the summary. NOCA patients are far more likely to be female, largely similar severity of ischemia on a stress echo to coronary artery disease patients. This is fascinating to me. In half of INOCA patients, a stress echo normalized at 1 year. 45% was the same or got worse. Angina frequency improved by clinically meaningful amount in 59% of INOCA patients at 1 year. No correlation between change in angina and change in ischemia. I think it's a fascinating study, frankly. Very difficult to carry it out. And is telling you how many unknowns we have in this particular situation. Roxana?
So an incredibly important study as a subset of Harmony Reynolds will present this, and it is really such an important study. Ischemia with non-obstructive coronary disease, mostly seen in women, is a really important. These women do not do well. They present, and a lot of times they're actually told they're crazy, but actually there is a lot. This opens, I think, the field, and this study shows us how much unknowns there are, and the surprises that you saw with the relationship of angina and ischemia, as well as their long-term outcome, is tremendously important for future research. And I think that these investigators have done a great job in actually looking at the patients who didn't get included in the ischemia trial, but yet they were studied in the CHOW study, which is this particular study. So very, very important for us to put a lot of importance of this study. Also, for the, in the Lancet Commission for Women, this is one of the big recommendations that we are putting out, that we absolutely must be paying a lot more attention to the microvasculature and understand the pathobiology of what's going on here, because they do not do well over time.
Thank you, Roxana.
Yeah, thank you so much, Dr. Fuster. I think this study was just, as you said, absolutely fascinating and also very humbling. I, again, want to underscore, of course, that 2/3 of the women were women, but also that half of these patients had a primary complaint of shortness of breath. And this is very much in overlap with the heart failure with preserved ejection fraction phenomenon that we're seeing, many of whom are women. It's touted, in fact, to be more prevalent in women. And we are beginning to understand, or at least we think we're beginning to understand, that there is microvascular dysfunction that underlies this phenomenon or this syndrome. And we're also understanding that oftentimes this is brought about by exercise. And so I think there is an overlap here between ANOCA and heart failure with preserved ejection fraction, particularly in women. I also think that this teaches us how complex the pathogenesis of angina is and how many variables go into it. It is the personal perception of pain. It is exercise induced and our reactions to exercise. It's our autonomic nervous system that comes into play. And so I think all of these things are really interesting. What I would be very excited to learn more about is the exercise capacity in these patients, specifically by doing cardiopulmonary exercise testing, which is a subject of investigation. But overall, really exciting, and commend the investigators for doing it.
The microvasculature, I agree, is completely important. Now, David Adams, you always like to look at the structures, and you look like St. Thomas. You cut what you see, and you move. And here you see a lot, and you cannot do anything.
I was hoping you weren't going to ask me something about that trial, VF. I think they summarized it very well.
Thank you. Vivek, you have the last word.
Well, no, I just thanks for having me. I think it's a very interesting series of trials, and yeah, I'm looking forward to hopefully doing this in person one day.
Well, thank you very much to the four of you. This was fantastic. I think it was a great discussion. It's an interesting group of papers, and I think intellectually I found these papers very, very appealing, and certainly the discussion that we have. Okay, thanks to all of you. We'll see you soon, and let's move forward and agree that we have to really overcome the problem that we all are facing worldwide. Thank you.